So our introduction to renal physiology begins with looking at the functions of the renal system. And if we break this down into really simplistic terms, we know that the renal system, which is shown in the picture here, the kidneys, the ureters, and the bladder, and so forth, obviously play a role in altering the volume of the urine and determining what is reabsorbed by the body or excreted in the urine influences the osmolarity. We can influence the blood volume because the urine is water that comes from the blood. If we take and alter the volume, we should see that we can easily alter the pressure. Now, this is just based on a volume change, but there are also hormonal and chemical factors that play a huge role in regulating blood pressure. And one of the focuses that I'll have is talking about regulation of blood pH and this integration between the respiratory system and the renal system in regulating pH. That's called the acid-base balance. The importance of the renal system: 25% of cardiac output goes to the kidneys. That's not 25% to each one, that's 25% to the kidneys. And this is the highest single cardiac output designated or going to a specific target. In other words, more blood per unit time goes to your kidneys than any other place. We're going to be talking about 4 important terms and actions that the kidney is tasked to perform: filtration, reabsorption, secretion, and excretion. And I'll define those again in a much clearer in a new next slides coming up. But we take a look at all of the stuff that's going to be occurring here in the kidney. It is the place where we decide what is going to leave the blood to be filtered, for lack of a better word, by the kidney. And we can see that not so important to pay attention to all these facts down here, but that we have blood with waste. So we have blood going into the kidney, and then processes taking place so that things that are removed from the blood would be excreted as urine, and then the remaining blood that's been filtered comes back to the body. So conceptually, this is a really important role of the renal system. Now, this particular slide is my favorite slide for defining and kind of illustrating these terms. So when we have blood coming into the kidney, and it's going to be coming in, so this is where it comes in, and then it goes into the glomerulus, or the glomerular capillaries shown here, into something called Bowman's capsule. So this whole structure here is Bowman's capsule. That's also called the glomerulus. Glomerulus. That's the same name as this, same thing as this. But what happens here is we have this opportunity for filtration to occur, step 1. And so let's take a look at step 1, filtration. Filtration is just the movement of substances from the blood into the nephron. So this is the beginning upper portion of the nephron right here. So filtration is substances that move, and there's rules that govern how they move, but they'll go from the blood into the nephron. Reabsorption is step number 2, and if you look at this, it just says, oops, I decided I want some of that back. Whatever I put in as the filtration, I want back. So if you're healthy, about 90 to 95% of everything that undergoes filtration gets reabsorbed. On a good day, we ask for most of it back, and we'll talk about what those things are. Certain places along the renal system, we can say, I want to take some of the stuff that was in the blood and stick it back in. Like, oops, I made a mistake, let me just put this back in. I may not have filtered it and reabsorbed it. It could just be substances along certain parts of the nephron where we can secrete things, just to make sure that we're getting everything that we need to in the blood and excreted. So if it gets to this point, it's excretion. So this is a nice cartoon picture. You'll see this one again. First of all, you don't have to memorize everything in this table by any means, but if you look at the substances here in this column, and we look at all the things, glucose and sodium and chloride and water, protons, all these different things about, where along the different places in the nephron things happen. It's a very complicated. I mean, this slide is actually intended to say, wow, this really could be overwhelming if I let it be. But one of the things that we're going to focus on, besides water, is we'll focus on the bicarbonate and the protons, right? These are the hydrogen ions. And we'll see how these two things play a role in the pH of the body. And basically, the renal system says, do I need to hold on to these things, or do I need to excrete them as urine? And it selectively chooses what it needs to do based on the pH. Well, here's our first chance to take a look at a sort of a picture taking a step back. All the stuff that we talked about where we illustrated the filtration in the glomerulus happens right in here. You see where I'm drawing the circle? That's the blood coming in, and any filtration that occurs will happen there. And then if something is brought into the nephron, it follows this little squiggly line here. You've got the proximal convoluted tubule. I didn't circle that very well, so let me undo it. So proximal means it's right next to the glomerulus. Convoluted means it's squiggly. And then what happens is substances can travel along here. They will go into characteristic parts of, we've got this loop of Henle, we've got the collecting duct. We'll see these parts later, but basically all of the filtration, reabsorption, and secretion occur right here where I circled it. And anything that is going to be excreted makes its way down here. Okay? So let's take a look at a little bit different level to be aware, because this picture just shows you the parts of the kidney. This picture, again, looking at these four functions that are going to be happening, shows you something new. We can see that we've got the glomerulus here, I circle it in blue, where we're going to try to have the filtration occur, and substance would then move along the nephron in this sort of yellowish gold color. But what you see now in this picture is this nice network of vascular system around the nephron. And you can see it all along here. We can see as we get into the descending limb and the loop of Henle, and we see just surrounded by vessels. Well, this is good because if we want to reabsorb stuff, we can pull it back. We need vessels to be nearby. We want to secrete stuff. We need to have a network of vasculature nearby the nephron, and we sort of make our final decision. And if stuff gets over here to the collecting duct, it's going to go to the bladder. Well, this next section is going to talk about the concept of net filtration pressure. And the net filtration pressure is going to tell us really if we have the process of filtration occurring. Right? Filtration is movement of substances from the blood to the nephron. Now, this filtration pressure, this pressure represents a blood pressure, just like we've learned in cardio. A pressure of 120/80 has meaning to us. And so there's an actual blood pressure that gets down into the kidney. Now we're going to look at these forces that promote filtration. So the overall net filtration pressure is equal to the forces that promote filtration minus the forces that oppose filtration. And so we're going to look here, we're going to say this glomerular blood hydrostatic pressure promotes filtration, and I'm going to spell these out for you later. And these two forces oppose filtration. And the next slide I'll show you like sort of a drawing. So what we're talking about before we do these calculations and look at these forces is we're trying to see that there's a blood pressure obviously coming from the heart that's feeding into this vessel. And that glomerular blood hydrostatic pressure, we're trying to see can we get filtration. That's the force that's going to promote it, and we'll see that if a patient has really, really low blood pressure, maybe their kidneys won't be functioning normally. So we're going to be focusing on this area right now. So in the determinants of net filtration pressure, I want to make a little cartoon drawing for you and take a few minutes to explain these concepts to you. So I'm going to draw a vessel, and I'm going to make it big enough so I can draw stuff inside of it. Then I'm going to surround the vessel by the glomerulus, or Bowman's capsule, which is the same thing, so it looks like this. And as we finish the drawing, we'll say if substances get to this spot over here where the star is, then filtration has occurred, and those substances are called the filtrate. Okay, and it then goes here to the proximal convoluted tubule. But we first have to figure out what are the forces that are taking place here. Can the filtration occur? Now, if we look at the first factor, and this was written down for you on one of the previous slides, so I only have room here to abbreviate it, but we'll put right here the glomerular blood hydrostatic pressure. So glomerular blood, well, this whole thing is the glomerulus, and I'm in the blood vessel, so the glomerular blood hydrostatic pressure. The hydrostatic pressure just means there is a blood pressure that exists and exerts a force to promote filtration. So we would draw it like this. We would say if blood pressure was really high, we would have a high glomerular blood hydrostatic pressure and be forcing filtrate to occur. Now in Bowman's capsule, in this capsular space, we have capsular hydrostatic pressure, and that's a hydrostatic pressure as well, and that acts to oppose filtration. So just looking at this, if the capsular hydrostatic pressure was higher than the glomerular blood hydrostatic pressure, you would not get any filtration occurring. And the third force, the one that seems could sort of potentially be a little confusing, is called the blood colloid osmotic pressure. So we're in the blood, that's a good sign. The colloid osmotic pressure says that there are suspended particles, these colloid particles. I'm going to make them this sort of blue color, and I'm going to draw them here. Now these are typically large proteins. They're too large to cross this thin vessel wall, so they're not really designed to go across and play a role in filtration. But the role that they do play in filtration is because they are large particles and they're not equal on both sides, so it's not isoosmotic. If I was going to make it isoosmotic, I would take these three and move them over here. I'd have equal concentration on both sides, but I can't do that. So the presence of these large proteins that can't cross the vessel wall create an osmotic pressure. So the water wants to go in here in an effort to dilute these to be isoosmotic. It'll never attain an isoosmotic state because these can't get over here. So when we look at this, we say, okay, we've got the three forces. The blood colloid osmotic pressure also opposes filtration. So from the standpoint of looking at some calculations, we'd say the net filtration pressure equals the glomerular blood hydrostatic pressure minus the sum of the capsular hydrostatic pressure and the blood colloid osmotic pressure. And we look at these. Hopefully this is a little bit more clear. This force promotes filtration and these oppose filtration. And if we were going to look at this from the standpoint of what we could see in numbers, because this might be something you have to calculate, I'll give you an example. So in calculating this, if a person's blood pressure was 120/80 in their brachial artery, like we check at the grocery store, then the glomerular blood hydrostatic pressure is about 50 millimeters of mercury. So net filtration pressure Let me draw this where it looks like I know how to write. Hold on. Net filtration pressure equals 50. This is all in millimeters of mercury, by the way. 50, that's the glomerular blood hydrostatic pressure, minus the hydrostatic pressure in the capsule is 10, and the blood oncotic pressure is 30. So if we do this math, we say the net filtration pressure equals 50 minus 40, so the net filtration pressure equals 10 millimeters of mercury. We can see that at these pressures, especially given what is considered normal, that if a person has low pressure, if they're hypotensive, then all these numbers decrease, and we would imagine that all we'd have to do is have the glomerular blood hydrostatic pressure drop to a level of 40, and we do the math, and the net filtration pressure is 0, and this person then is at risk for having some problems with their renal system. So this is an important calculation to understand, and especially in understanding as a summary that these three forces, what they are, how they influence it, how if one of them changes, we're going to get a change in the overall net filtration pressure. Well, one of the things that we have to explore and understand is that once we do get substances in filtration occurs, all that happens right here. I just made that big purple circle. And then we have rules about the permeability of the nephron. And the basic rules are that the loop of Henle on the descending portion is only permeable to water. So we can see all the little circles that say water is coming out. And as the water comes out, the osmolarity, shown here in numbers inside the nephron, is increasing. So it's a pretty highly osmotic solution here. As we move back up, and then again we have water that can get picked up as it leaves the nephron, it can get picked up by the blood, so we don't lose our blood volume. And we'll talk later about how different things can change along the way, but then in this thick ascending limb shown here, obviously it's thicker and it's ascending, it's permeable to substances, usually with transporters and different rules that apply, and we'll see some sodium chloride transporters and different things here, sodium potassium exchanger, and we'll talk about those. But the main thing is understand that the descending part is permeable to water, the ascending part is potentially permeable to other things, and so potentially the ability to alter stuff as we go. And again, finally, as we make our way, we have hormones and different substances that can play a role. I would say in this half of it, we finally decide, the body decides what it wants to put into the urine. Now, before we talk about the respiratory renal integration, I want to emphasize, these four functions. And what we're gonna focus on now is what does the kidney do with the hydrogen ions or the bicarbonate ions as it decides based on the body's pH. So if we can imagine then, if the body was very alkaline, that the renal system might say, well, if we don't have enough hydrogen ions and we're alkaline, maybe I'll reabsorb more of these, and maybe I'll excrete more of these. So just from the concept of these two substances and these four functions, we're going to go and look at this integration. And keep in mind, this is a slide you've already seen before, but it's important for you to understand that the hydration of CO2 equation, shown here at the bottom, that gives us carbonic acid, can produce the bicarbonate ion and the hydrogen ions. And so we're going to make this connection between lots of CO2 will ultimately give us lots of hydrogen ions. And we can alter the CO2 in the body by how we breathe. And what you can see here in this picture showing the bar-headed goose that flies over the peak of Mount Everest, and a person here trying to stand on top of a high mountain, is some of the examples that we're going to use in these different functions. But really important just to emphasize that if the respiratory system is going to participate, it has basically two choices. It can say, I can influence the CO2, and therefore I can influence the hydrogen ions, and therefore I can influence the pH. Now I'm saying influence because I'm not picking a direction right now. So this is really important. If I hyperventilate, I'll just write it up over here where I have some space. So hyper, that's more ventilation than normal. That's going to cause an increased exhalation of CO2, so a decrease in the PCO2 in the body. We're going to get rid of more CO2 than normal. So in that case, with hyper, we would decrease the CO2, we would decrease the hydrogen ions, and we would increase the pH, and we'd be alkaline. Now, conversely, if we hypoventilate, and just think of holding your breath, if you are holding your breath, you're not eliminating CO2. So if we hypoventilate, and this can occur the patient that's sick, we're going to increase the PCO2 in the body. Okay? And then we'd see with hypoventilation, these values here would all change. Let's take a look at these considerations. Okay, the four conditions are two acidotic and two alkalotic conditions. The first two caused by the respiratory system, and the compensation will be by the renal system. And the last two caused by some other metabolic problem, not the respiratory system. So the respiratory system can play a role in trying to fix the pH imbalance. The next 4 slides we'll walk through each of these, and we'll say what is happening and how, an example of how this could happen here, and what's the compensation to attempt to restore the pH. The key thing to understand here, as I describe this to you, is if it's a respiratory problem, the respiratory system can't fix it. The renal system fixes it. If it's a metabolic problem, the respiratory system can certainly fix it, and we won't discount the fact that the renal system is working, but that's what we're going to look at. So we're going to say if there's some respiratory problem that's causing a pH change, we're going to look to the renal system for this compensation. That means how to fix it. If it's a metabolic problem, we're going to look at how the respiratory system plays a role in fixing it. And then again, that's not to say that the renal system isn't working here. We'll go over that. Okay, respiratory acidosis. Now I'm going to explain this in ways that are really, really simple, really simplify this, because this is how I want you to think about it when you see these types of problems, whether they're easy recall or important critical thinking. Okay, respiratory acidosis. This term tells me that I have too much free hydrogen. I'm acidic. It says that my respiratory system played a role in that, so then I can conclude, well, I must have too much carbon dioxide. And too much carbon dioxide actually gave me the hydrogen, but I'm showing how I just use this term here to derive in a logical fashion. If I have too much carbon dioxide in the body, then I ask myself this simple question. Am I hypoventilating or am I hyperventilating? Remember, if I'm hyperventilating, I'm exhaling more and more CO2. If you can't remember, just hold your breath. That's the most extreme case of hypoventilation. So if I'm not ventilating very well, if I'm hypoventilating, then I would accumulate CO2, free hydrogen, and become acidotic. Now, what's an example of this? Classic example would be a person with pneumonia. The person with pneumonia, they may be breathing very heavily, but a great portion of their gas exchanger is not effective because it's filled with bacteria and water. So this is our example, and you would see this person, regardless of how they're breathing, they are not ventilating, they're not exchanging gases very well. Very simply, how does the renal system try to fix it? So we'll call this renal compensation, and we just list the two things that we know contribute to acidosis and buffering. So these are two choices. We have too much free hydrogen as a result of a respiratory disturbance, which means this hydrogen in the kidney will be excreted. And the bicarbonate will be reabsorbed. Okay, so this is what we're doing to these two things to fix this problem. Now, if we take the same approach, hopefully then this becomes easier to sort of attack and assess. Alkalosis says that we have not enough hydrogen ions. That means the body has too little CO2. And how do we get too little CO2? Do we basically hold our breath and hypoventilate, or do we experience hyperventilation? Well, so hopefully if you're paying attention and working this through, you'd say, well, if we hyperventilate, we would exhale more CO2 than normal. We're reducing the PCO2 in the body. Don't have enough free hydrogen, so the body is alkalotic. I'll explain to you a classic example of how this occurs, and the example consists of going to high altitude. I mentioned this before. As we go to high altitude, we experience hypoxia because the PO2 of oxygen, PO2 is less. So the hypoxia causes an increase in breathing. And this increase in breathing is associated in a healthy person with an increase in ventilation. So we're exhaling more of the CO2. Increased breathing causes an increase in the exhalation. Every exhalation is filled with CO2, so we're hyperventilating here and eliminating more CO2 from the body. That means it's being reduced. And that's fine. We can then hopefully rather easily go and look at the compensation by the renal system. Okay, so we have two choices. What do we want to do with this stuff? Okay, we're alkalotic, so obviously we want to reabsorb this one. So we'll increase reabsorption, pull it back into the body, and here we'll have more excretion, so we don't buffer, and we can pull the pH back down to a more normal and slightly acidic value than the alkalosis that we're experiencing. For metabolic acidosis, this is now a problem with some metabolic process, but we still know that we have too much hydrogen ions. We don't really equate this the same way to CO2 because it's not the same problem. And what we do is we say, okay, we just have to go right into our example. And our example is something we've talked about before. Diabetic ketoacidosis. This is a person that has too many hydrogen ions due to ketoacidosis. So we've talked about that. That's what's happening. How did it happen? Well, it happened because we needed to utilize fatty acids, and the byproduct in the ketones is the increased production of protons. So the example is diabetic ketoacidosis, and then we take a look at what the respiratory system can try to do. And this is the part of the integration that I just think is, to me personally, is really fascinating, because most people don't make this integration between the two systems. What the respiratory system wants to do to try to compensate and fix it is as follows. The respiratory system says, hey, I can influence hydrogen. Well, I have to influence CO2. So the compensation says, the respiratory system says, how does the respiratory system play a role to decrease hydrogen ions in the body? And then we have to make that connection that we made earlier when we were sort of diagnosing the problem. We want to decrease the hydrogen ion in the body. Then we know what we need to do is decrease the partial pressure of CO2 in the body. And then we ask ourselves, do we decrease the CO2 in the body by hypoventilating or by hyperventilating? Well, if I hold my breath, again, which is said now for the third time, is a classic example of the extreme hypoventilation, I would increase the CO2 in my body. So the person that's experiencing diabetic ketoacidosis would be hyperventilating in an attempt to eliminate hydrogen ions and CO2 in contributing to the acidosis they're experiencing from the ketoacidosis. Our last condition is metabolic alkalosis. So not enough of these. And so one of the things that we can see when we look at this as examples is we can maybe tie in something that might be a little easy to remember, but excessive vomiting, they call that loss of gastric juices. So getting rid of all that gastric juice and all that acid. So vomiting, excessive vomiting, it can be anything associated with food poisoning, consuming too much alcohol, having a stomach flu, just being sick. And often we combine that with the excessive ingestion of antacids, especially if we feel like, oh, we have an upset stomach, we drank too much alcohol, so all we're doing the next day is eating antacids, or with food poisoning or upset stomach. These two things then would contribute to the alkalosis. Here, we're losing the hydrogen ions as we throw up, and here we're basically eating bicarbonate, so we're buffering that, and we become alkalotic. So what the respiratory system does in its compensation is it says, I can play a role, because the respiratory system says, I can increase hydrogen ions in the body. To do that, I have to increase the PCO2 in the body. And how do I increase the PCO2 in the body? Do I hypoventilate or do I hyperventilate? And it's not just simply memorizing that, oh, on the last one I circled here, so it has to be the other one. Just stop and think, because you'll be getting these concepts in different times during the test. You'll say, okay, if I need to increase the CO2 in the body to help the alkalosis I'm experiencing pull the pH back down to a more acidic value, a normal acidic value, then I need to hypoventilate. Okay? And so the breathing will decrease in its rate and volume in an effort to retain more CO2, not exhale it as much. Metabolic acidosis, all these mechanisms that we see with the renal system and the respiratory system as compensation are fairly good in bringing back the slight changes that we need within these physiological limits of pH. Metabolic alkalosis is one of those where we have a difficult time, because if hypoventilation is what we're trying to do, hypoventilation would cause an increase, right, in the PCO2 in the body, and that's important. But what we also know from previous lectures is an increase in PCO2 is a potent stimuli of breathing, so we'd have an increase in breathing. So it's really hard to have complete compensation along the lines of this.